So we'll go over some of the orthopedic disorders related to the spine here, and we'll do, as always, a quick anatomy review. We'll talk about the degeneration of the spine just due to simple aging, and then we'll talk about 7 disorders of the spine. The one we're not going to talk about, but is a very important one, is also the most common disorder of the spine, is scoliosis, and I gave an entire section to scoliosis. So mostly focus on the right here. This is the spine as a whole. So there are 7 cervical vertebrae, 12 thoracic vertebrae, 5 lumbar vertebrae, and then there are 5 fused sacral vertebrae and 4 coccygeal vertebrae, which are also fused. The sacral vertebrae are collectively generally referred to as the sacrum, and same with the coccygeal vertebrae, referred to as the coccyx. The way I like to remember the 7, 12, and 5, cervical, thoracic, and lumbar, is that you wake up at 7 in the morning and have breakfast, you have lunch at 12 in the afternoon, and you have dinner at 5 o'clock in the evening. So 7, 12, and 5, cervical, thoracic, and lumbar. All right. This is looking at a thoracic vertebrae, and for the most part, the vertebrae look alike, but they are different as far as size, relative size of, say, the body and the processes. So none of them are exactly the same, but for the most part, they share similar features. So starting on the anterior side, we have the body, and the body takes on most of the force. If you're standing up, the force due to gravity, the body takes on most of the force. You have, on your thoracic vertebrae, you have the costal facets, and the costal facets is for communication with the ribs. These don't exist on like lumbar vertebrae or the higher cervical vertebrae. You also have an articular facet, superior and inferior, and these are going to be on both sides. So you'll have a superior articular facet on both sides and an inferior articular facet on both sides, but you can't see the inferior articular facet because this is a superior view. And it's the articular facets that also form a joint with the vertebrae above it and below it. And this is actually a true joint. So this is a synovial joint. The superior articular facet will form a joint, a synovial joint, with the inferior articular facet of the vertebra above it. And this together is known as a facet joint. So you have 2 facet joints on each vertebrae, on each side, 2 on the superior side and 2 on the inferior side. So the facet joint is just the superior articular facet forming a joint with the inferior articular facet above it. You also have these processes, the transverse process and the spinous process. The spinous process is going to be the most posterior part of the vertebra. The transverse process will form the most lateral process of the vertebra. And it's in between these that you have the lamina of the vertebra. So this is looking at the vertebrae from an oblique view. So we're looking at it from an anterior and right view at about a 45-degree angle. And what I want to point out is that facet joint. So here you have an inferior articular facet. This one being of would be probably a continuation from L3, which you can't see here. Oh no, this would be from L4. And then you have the superior articular facet of L5. And that forms a facet joint. And you would have the same thing on this side, you just can't see it. And then you'd have the same thing down here and right there. So you've got a lot of these facet joints. And they're just the articulation of these articular processes. And then also you have a disc. So remember that the body of the vertebrae is what takes on the most of the weight due to gravity. In between the vertebrae, you have these discs, and these discs are formed of collagen and water and matrix. And there's 2 parts of the disc. the capsule, which is also called the annulus, and then the pulp, which is also called the nucleus pulposus. And together this forms these intervertebral discs, and you have these discs between each vertebrae. Now, degeneration of the spine. Depressingly, degeneration of the spine occurs starting roughly in your mid to late 20s. That's really sad, considering that it's widely considered the prime of your life. But aging-related degeneration is normal to a certain degree. Now, there are risk factors that can cause a faster degeneration and hence increase your risk for some of the various spinal diseases that we're going to talk about. And these risk factors include modifiable risk factors such as alcoholism, smoking, obesity, occupational risk factors like manual labor, hard manual labor, and athletic activities. And then non-modifiable risk factors such as your race. Black race tends to be associated with more spinal disease, faster degeneration, and then of course age, genetics, and coexisting conditions. The spine and intervertebral discs undergo significant aging-related degeneration, and it's the intervertebral discs that start. So the nucleus pulposus of the disc becomes stiffer due to collagen deposition starting in the mid to late 20s. And it's because of this that the discs become narrower. So because they're formed then with collagen, they can become more dense. And because they can become more dense, the bodies of the vertebrae start to get closer together, and because then they're closer together, the spine has less mobility, and because it has less mobility, it's going to be less stable. And so these changes in the intervertebral discs contribute to decreased stability of the spine, and this can lead to bone spur formation, which is also known as an osteophyte complex. This can be either in or around the disc or elsewhere in the spine, particularly that area known as the lamina, right here, and the articular facets. So there are these two major joints that I referred to earlier that I want to really point out again here. This is a lateral view of the spine. This is going to be your transverse process will be coming at you, and then your spinous process back here. But here's your facet joint, which is also called the zygoapophyseal joint. We'll just call it the facet joint. And remember, that's just the superior articular process of one joint with the inferior articular process of the spine of the vertebra above it. So here is a zygoapophyseal joint, and this is a facet joint. And this is actually a true synovial joint, so you actually have synovial fluid here, and this is commonly affected in patients with osteoarthritis because that affects synovial joints. You also have your intervertebral disc, which also is a joint of sorts, and it's important because the body takes on most of the force because it's the largest, it's the strongest. So here's your intervertebral disc. Spondylosis is the degeneration of the interfaces between the vertebrae. So these interfaces here, like the intervertebral disc and the zygoapophyseal or facet joint. And that's the degeneration of those is just called spondylosis. That's a name that just refers to all of that. So when you have degeneration of your facet joint, we particularly call that facet arthropathy, and we're going to talk about that in detail. Degeneration of the vertebral discs is just referred to as degenerative disc disease, which increases your risk of disc herniation, which is a particular problem which can cause compression on the spinal nerves and also possibly on the spinal cord itself. And then spinal canal narrowing is also a result of degeneration of the spine. and that causes spinal stenosis. It is spinal stenosis. The clinical consequences of spondylosis, of this degeneration of the spine, range. So it just depends on how severe it is. It can range from back pain, which can be mild or severe. Pretty much everybody's going to experience some level of lower back pain in their life as they get older. It can also cause radiculopathy. Radiculopathy is the compression of a nerve root. And then myelopathy, which is the compression of the spinal cord itself. And myelopathy tends to be either caused by spinal canal narrowing, which is spinal stenosis, or disc herniation, which can then press right on to that onto to the spinal cord. So here's a perfect example. Here's your disc capsule right here, and it can go right up against that nerve sac. Okay. Now it's important to keep your terms straight. So remember, we talked about spondylosis, which is just degeneration of the interfaces of the vertebrae, the facet joint, your interarticular discs. There's also spondylitis, which is not the same as spondylosis. Spondylitis is a general term for an inflammatory disorder of the spine. Then there's spondylolysis, which is a fancy name for a spinal stress fracture. Stress fracture doesn't really do it much justice, since it's a little bit more severe than a stress fracture, but it shares some similarities to a stress fracture. So we'll talk about spondylolysis towards the end here. And then spondylolisthesis, which is a malalignment of the vertebrae along the intervertebral discs, and this is usually due to multiple cases of spondylolysis. So important to keep these terms straight, because they look similar, but they're not the same. So facet arthropathy. This can occur at any level. So it can occur at the cervical level, thoracic level, anywhere. But what we're going to talk about is lumbar facet arthropathy, because this is far and away the most common place to have facet arthropathy. And this is a common cause of lower back pain. And remember that the facet joint takes on a lot of the force due to gravity. So if you're just standing, it's pretty much the body of your vertebrae and your facet joints taking on all of the force. And with various movements such as rotational motion and vertical motion and shear, the facet joint takes on a lot of that too. So when you rotate left to right, it's pretty much your facet joint taking on all of the force there. And then with vertical compression, that's just standing up, the gravity compression. The facet joint takes on a lot of force there. However, it would be the discs that are taking on most of the compression. And then shear, anterior, posterior movement, that also puts force on the lumbar facets, all of the facets really. So the facet joint simply takes on a lot of force. And so because of that, it is a common place for arthritis to occur. Risk factors for facet arthropathy are similar to those in any patient with degenerative disease of the spine, and those include old age, osteoarthritis. However, other things like ankylosing spondylitis and RA are also possible aggravators of the facet joint. As far as the history, we tend to see facet arthropathy in older patients with chronic low back pain. And most importantly, this is going to be chronic low back pain that does not have neurologic symptoms. And this sets it apart from some of the other back pains that you can get that can have neurologic symptoms. And it makes sense that you wouldn't have neurologic symptoms here because the facet joints are far away from the spinal cord. Now, you can have neurologic symptoms if you have abnormalities, if you have osteophytes of your facet joint, but that's not what we're talking about here. We're talking simply here about about arthritis of the facets. So this is chronic lower back pain, and it's usually described as a dull and wrapping pain. usually worsened with particular movements like rotating or bending over. So for diagnosis, it's pretty much clinical. This is a very common cause of lower back pain, especially in an older patient with arthritis. Most importantly here, the neurologic exam is, for the most part, normal. It's not facet arthropathy. If you have impingement of the nerve, then the diagnosis is going to be different. Just normal facet arthropathy is just irritation of the facet joint. So the neurologic exam for a patient with simple facet arthropathy should be normal. Imaging can be performed to rule out other possible causes of back pain, but it's not going to diagnose facet arthropathy. The treatment for facet arthropathy is intra-articular steroid and anesthetic injections, and that's done under fluoroscopic guidance. This is the treatment of choice. It also, if it's successful, happens to be diagnostic of facet arthropathy because what you're doing is you're injecting it into the joint space, the facet joint space, and if the pain goes away, then you knew that's where the pain was coming from, and that is actually the best way to diagnose facet arthropathy. So it just happens that the treatment is the best way to diagnose. So that's why you have to make the clinical diagnosis. NSAIDs can be taken as well. Okay, so remember what I said, that if with facet arthropathy, you don't have neurologic symptoms. You can get that osteophyte complex that's due to normal degeneration of the spine, and that can be at your facets. But if you have that osteophyte complex, what you then have, what you can get is a radiculopathy, and that's if it impinges upon a spinal nerve. And again, this most commonly happens in the lumbar region. So we're going to talk here particularly about lumbar radiculopathy. So lumbar radiculopathy is the compression of a lumbar spinal nerve root, and this again can be due to just regular old spinal nerve or spinal degeneration. But what we have here particularly now is a nerve problem, because what you're getting is some kind of problematic remodelization of the bone that is now causing an impingement upon a nerve. With facet arthropathy, it was just a joint problem. You didn't have any nerve issues there. Now we have impingement of a nerve. And this can happen at any level. It can be cervical, it can be thoracic, it can be lumbar, but most commonly it's lumbar. And most commonly, even when it's lumbar, it tends to happen at L5. Spinal nerve compression can be due to multiple causes, but most commonly it's due to that osteophyte complex formation that I have been referring to, or to disc herniation, so actual herniation of the intervertebral discs. Risk factors here include anything that can cause hastened degeneration of the spine, as well as heavy manual labor. So what do we see as far as history in these patients? These are usually older patients with a history of chronic back pain, just like what we saw in the facet arthropathy. But with these patients, they have radiculopathic symptoms. And radiculopathic symptoms vary based on, of course, what nerve is being impinged. But for the most part, what you have with radiculopathy is this pain that radiates, and it's usually described as aching, burning, or like an electric shock. And if you know that this is a radiating pain, and it's associated with back pain, for the most part, that really clues you in on radiculopathy. Now, if you've ever dealt with a patient with sciatica, lumbar radiculopathy is a possible cause of sciatica. However, there are many causes of sciatica. So the pain, as mentioned, is often described as aching, burning, or like an electric shock. The pain is only one feature of radiculopathy. There are also paresthesias, weakness, and numbness, depending on, again, what the nerve is that's being affected. So as mentioned, radiculopathy is compression of a spinal nerve root, and the spinal nerve compression can be caused from osteophyte formation or disc herniation. So here's an example of what could cause the radiculopathy. So this is normal here. So you have your intervertebral disc, and then you have here your spinal nerve emerging from the spinal canal. Here you have a herniation of the intervertebral disc, and that can impinge upon the nerve. So the symptoms tend to be worse with prolonged activity and extended sitting. There are also various positions that can make the pain worse. A lot of patients will say that the symptoms are improved with rest and laying down. The precise location and distribution of the symptoms are going to depend on the exact spinal nerve root affected, and I've said this a few times, but I can't stress it enough because this can present as foot pain, lower leg pain, it can present as arm pain, it can present as leg pain, so this can present as many different ways. What ties it together, however, is that the pain is described as this aching, burning, or electric shock-like sensation, and it's also associated with paresthesias, weakness, and numbness. So you do have these neurologic symptoms as well as pain. Now, when you have lumbar radiculopathy, and when I say lumbar radiculopathy, what I'm primarily referring to is anything L4 or below, or L3 or below. So even referring to sacral nerves as well. What you're notably going to have is a positive straight leg raise sign. So what you do is, on physical exam, you flex the leg at the hip to 90 degrees, and the patient will note their symptoms. That aching or burning thing, whatever's going on, whatever pain they're describing, you'll elicit that when you do this test. You can also, on physical exam, see gait abnormalities, and we'll discover why in a little bit. So this is the straight leg raise test. A lot of times you don't have to go all the way up to 90 degrees. A positive straight leg raise test is positive as soon as they experience the pain or the symptoms. So these are the most common areas to have radiculopathy, L4, L5, and S1. L5 being the most common. So these are the ones you should remember for the USMLE. So L4 is a numbness and weakness of the leg. What's important to remember here is that you have a diminished patellar reflex and you don't have any symptoms at your feet. With L5, this is the most common. You have numbness of your leg, and it tends to be along the lateral side of the leg and on the back of the leg. And you have weakness on dorsiflexing. What is dorsiflexing? It's the opposite of standing on your tippy toes. So if you're walking on your heels. So if you tell these patients to walk on their heels, they're going to have difficulty doing that because the dorsiflexors, the muscles in their leg that are responsible for dorsiflexion, are going to be weak. So patients with L5 nerve root compromise are going to have difficulty walking on their heel. With S1 impingement, you're going to have numbness on the back of the leg and also on the sole of the foot. So these patients will have weakness on plantar flexing, so these patients will have difficulty walking on their tippy toes, and they'll also have a diminished Achilles reflex with S1 impingement. And then S2, 3, and 4 impingement, which we don't see here, these cause sexual dysfunction, bowel and bladder problems, saddle anesthesia, and this is associated usually with the Cauda equina syndrome. Now important, again, I just said this, important to differentiate lumbar radiculopathy from Cauda equina syndrome, which also presents with back pain, similar sensations, referral to the leg, lower extremity weakness, paresthesias, numbness, and so forth. With Cauda equina syndrome, it tends to include bowel and bladder dysfunction, sexual dysfunction, and saddle distribution anesthesia, which would be anesthesia more over the perineum, down here, around the butt. Okay, treatment for radiculopathy can be either conservative or surgical. That's going to depend on the orthopedic surgeon. You don't have to worry about making that call. It usually depends on the severity and comorbidity. Spinal stenosis. This is a narrowing of the spinal canal, and this is also due generally to aging, just because of the changes of the bone. However, there are multiple factors that can result in spinal stenosis, many of them including congenital causes, as well as trauma and neoplasm. It's usually the cervical and lumbar spine that becomes stenosed. The thoracic spine is rarely stenosed. Symptoms here include chronic neck or lower back pain, of course, depending on what part of the spine is stenosed. Neurologically, you're also going to have symptoms, of course, here because you have stenosis of your spinal canal, and you can't affect the spinal canal without affecting the spinal cord. So numbness, paresthesias, and weakness are going to predominate. Unlike in radiculopathy, with spinal stenosis, the symptoms should be bilateral. And of course, it's going to be bilateral because it's affecting the spinal canal. With radiculopathy, you're directly affecting a spinal nerve, and that's only going to be on one side or the other. Bowel and bladder weakness can occur in some of the lower stenoses. So if you get down to S1, S2, S3, that can start that can cause bowel and bladder weakness. For diagnosis, for spinal stenosis, if you suspect a stenosis, you should get an MRI. That's the only way to detect spinal stenosis. And you should really suspect spinal stenosis if you have bilateral symptoms. If they're only unilateral, you should suspect some kind of impingement, like a radiculopathy. For the most part, though, they are similar in appearance to radiculopathy. Spinal stenosis and radiculopathy are similar in appearance. The difference, major difference, is that with spinal stenosis, it's bilateral. So here is a cervical spinal stenosis, and all you have to do is look at the brain. Here's your spinal cord, and this should be this nice, you should have these nice parallel lines here, like down here. Here's your impingement, right here. Here's another one. This is lumbar, and then here's another one. So yeah, like I said, the best test is MRI. Okay, what's wrong with this spine? What are these? So this is a lateral view. So those are the spinous processes, or spinal processes. I should say spinous processes. And what do we have here? We can't see our spinous processes because they're fused. And fusion of the lumbar spinal processes is the salient feature of ankylosing spondylitis. So ankylosing spondylitis is another spinal disease, and this is actually an autoimmune disease. It's a seronegative autoimmune disease, and this you see a lot of times in association with like psoriatic arthritis, enteropathic arthropathy, reactive arthritis, which is also known as Reiter syndrome, because these are all the seronegative spondyloarthropathies. So ankylosing spondylitis falls into that class. And like all of the seronegative spondyloarthropathies, it is HLA-B27 positive. So they just call it seronegative because there's no autoantibodies that are formed here. And this is an autoimmune disorder, so we would expect some kind of autoantibody to form, but indeed with ankylosing spondylitis we don't have one, and that's why it's called seronegative. So this is an autoimmune disorder affecting the axial skeleton, primarily the lumbar spine. It can also affect the shoulder and the hips. What makes this one distinct from some of the other autoimmune disorders that you know about is that Ankylosing spondylitis is predominant in men by about a 4-to-1 ratio, whereas most autoimmune disorders like lupus or RA tend to be in women. And it also occurs in quite young men, so 20s, 30s, this can happen. The primary complaint in ankylosing spondylitis is persistent and chronic lower back pain. And so really when you see a younger patient with chronic lower back pain, this is definitely something that should be high on your differential. Young people just don't get chronic back pain. It's fine to have, once in a while pain, but if it's chronic back pain that does not go away with NSAIDs, this is very suspicious for ankylosing spondylitis. Another feature that helps you realize that it's an autoimmune disease is, like other autoimmune diseases, like for instance RA, it's worse in the morning and improves throughout the day, and that's just pointing to the inflammatory features of the disease. On examination, patients with ankylosing spondylitis will have a loss of lumbar lordosis, and that makes perfect sense because here's the lumbar spine here. Here's where your lordosis is. Remember, lordosis is just that curvature pointing towards the anterior side. So this would be your normal lordosis here, but your curvature of the spine is along the spinal processes here. And that is a loss of lordosis. So a loss of lumbar lordosis is one of the big physical features that you should see, and that's just due to the fusion of the spinal processes. And that's because of the chronic inflammation. And this also makes the patient more susceptible to a spinal fracture. For diagnosis, the best initial test is going to be the lumbar spinal x-ray, and that's the best first step. You could probably do other imaging tests after that, but for the USMLE, a lumbar spinal x-ray is the best test to get. And you should get multiple views, but really that spinal view, that bamboo spine, as they call it, is makes it quite obvious. So this is ankylosing spondylitis here. This is the bamboo spine, as you can see right here. And this is a patient over 25 years. Unfortunately, before the really good therapies came along for ankylosing spondylitis, and so there's just this loss of lumbar lordosis here. You can see affecting his stature. So here's normal lumbar lordosis, probably when he was very soon after he was diagnosed. It's kind of harder to see it here because he's starting to lose that lordosis. You can see very little lordosis here. Here's a bamboo spine. So just this looks like bamboo. This is bamboo here. So radiologists come up with some really creative names. My favorite one is coming up. What do we do for treatment for ankylosing spondylitis? The best first step is going to be NSAIDs and physical therapy. Second line therapy, which is pretty much universal, is TNF blockers. And that includes infliximab, adalimumab, etanercept, golimumab. There's tons of them now. And these are very, very good drugs. Unfortunately, they reduce your immunity. So you need to test for TB before you administer these drugs or prescribe these drugs, but they are quite effective. Cauda equina syndrome. So you're wondering why I have a picture of a horse's butt here. And the reason is because Cauda equina is the Latin word for horse's tail. And really, when you look at the Cauda equina, which is the terminal part of your spinal cord, it looks like a horse's tail. And here's a picture of it. So it kind of looks like a horse's tail. Okay, so the Cauda equina are a set of intradural nerves that provide sensory and motor innervation from the levels of L2 to S5, which would be the end of the spinal cord. And herniated disc is the #1 cause of Cauda equina syndrome. And so this makes perfect sense that this is going to be something that can happen with age, because what increases with age? Herniated discs. And so with age, your risk of Cauda equina syndrome goes up. Now the spinal cord tapers off roughly at L2, and that's called the conus medullaris. And after L2, then all of your nerve roots are deriving from this Cauda equina, which this is my little illustration that I made here. But this is what it kind of looks like. So you have this conus medullaris here, and then your Cauda equina, which then connects as the filum terminale. The nerve roots of the Cauda equina provide sensory and motor innervation to the hip muscles, lower extremity muscles, as well as urinary and anal sphincters, as well as muscles important for sexual function. What can cause Cauda equina syndrome? #1 cause is disc herniation. Other things, lumbar spinal stenosis, trauma, neoplasm, infection or abscess, inflammatory disease, chronic inflammatory demyelinated polyarthropathy, or neuropathy, Paget's disease, and ankylosing spondylitis. So history in a patient with Cauda equina syndrome tends to be an older patient, because as we age, the intervertebral discs, as we've talked about, degenerate, and that's a risk factor for CES. Trauma, cancer, or other risk factors. These patients tend to present with dull lower back pain along with the neurologic symptoms that are typical of Cauda equina syndrome. So lower back pain, then neurologic symptoms of lower extremity weakness, which could be unilateral or bilateral. They can also have sensory deficits of the lower extremity, paresthesias, loss of sphincter tone, which can result in urinary or fecal incontinence, sexual problems, and then fasciculations and reduced or absent deep tendon reflexes. And this is all going to depend on where exactly the compression is, if it's due to an intervertebral disc compression. On physical exam, you'll have reduced lower extremity strength. You'll have reduced sensation over particular dermatomes. Again, this is all dependent on where exactly the pathology is on the Cauda equina. You can have reduced or absent deep tendon reflexes, reduced or absent cremasteric reflexes, or reduced or absent bulbar cavernosus reflex. Sorry, my pronunciation is just terrible tonight. All patients where you suspect Cauda equina syndrome, and that's really any patient where you've got this loss of sphincter tone, incontinence, along with back pain, you should get an MRI. And provided that the patient is stable, this is the best first step. The underlying cause needs to be found. Usually that can be found on MRI. However, if you don't see anything on MRI, a chest x-ray is indicated, as lung cancer is a common cause if it's metastatic. If the patient has meningismal signs, then you should get a CSF analysis. But for the most part, as I mentioned, the #1 cause is intervertebral discs protruding, and so then you'll be able to find this on the MRI. And this is saddle anesthesia, which is common with Cauda equina syndrome, and you should look for this saddle anesthesia on the USMLE. This is one of the symptoms they like to give you, along with the incontinence. And saddle anesthesia is just anesthesia over those S1 to S5 dermatomes. The treatment for Cauda equina syndrome is usually rehabilitation, but it's going to depend on the cause, and you're not going to have to determine whether or not the patient needs surgery. Surgery is certainly on the table for these patients, pardon the pun. It's the orthopedic surgeon who will decide whether surgery is necessary. Spondylolysis is the most common, one of the most common cause of lower back pain in young people, particularly acute lower back pain. We tend to see spondylolysis in young athletes or older people with osteoporosis. About 95% of spondylolysis cases occur at L5. L5 tends to be a problem point in general for spinal disorders. It's the most common place to have a herniated disc, and it's also the most common place to have spondylolysis. Spondylolysis occurs from repetitive bending and straightening of the spine, and so you're going to see this really frequently in athletes, particularly in athletes that engage in these repetitive bending and straightening of the spine. So think like gymnasts that are doing those flips all the time, football linesmen that are crunched over, divers. Those are all people that you could see these the spondylolysis. And spondylolysis shares some similarities to stress fractures in as much as you can get it from repetitive movements. But the word stress fracture doesn't really do it much justice, because this can be a much more severe fracture than a regular old stress fracture. Unlike other stress fractures, point tenderness is not a salient feature, and that's just simply because this is a much more deep fracture than stress fractures usually are. The neuroexamination with spondylolysis should be unremarkable, and that's because this is a fracture of the spine far away from the spinal cord. What do we do for diagnosis? If you have the young patient that comes in with acute back pain that's aggravated by bending and they're an athlete, you should get an x-ray. And you should also get multiple views, as you would with any possible fracture. And the most important view that you're going to get is the oblique view, but you should get an AP view, a lateral view, and an oblique view. And the oblique view typically shows the Scotty dog sign. What a name. This is my favorite name that they've came up with. So here's your Scotty dog. Somebody had to be really, 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 really creative in finding this, but once you see it, you'll never forget it. So here's your superior articular process here, forming its facet joint with the inferior articular process. Here's L5, here's L4. So here's your facet joint. Here's your transverse process. So here's the nose of the dog. Here's the little waggy ear of the dog. Here's the inferior articular process of L5, forming its facet joint with S1. And then here's the foot. I believe this. I can't tell on this illustration, but I believe this is the spinous process here. So here's the back of the dog, and here's the other foot. So yes, this does look like a dog now that you look at it, but this is the only angle where you actually see that dog. Where you get the fracture is at this region called the pars intraarticularis, and that's just the region between the transverse, on the lamina between the transverse process and the spinous process. So this is the Scotty dog finding. So what you're looking for is okay, here's your series of Scotty dogs. Here, here, and here. Okay, so you got 3 dogs here. And what you're looking for is a collar around the dog. This is the collar here, and here is the collar. So here you have a continuation of the neck to the body of the dog, and here you have a collar. So right here is the fracture. This is 99th percentile stuff for the USMLE. I doubt you'll be asked to find this on boards. You will impress any surgeon or physician you work with if you can identify this finding. And this is the Scotty dog Monopoly piece. So it does look just like this. The treatment, because this is similar to stress fractures, rest is the best therapy. Surgery is rarely necessary. Metastasis to the spinal bone. Okay, this is a common place of metastasis, especially from breast and prostate. Symptoms include back pain. You can have neurologic signs consistent with cord compression because you can get because the tumor, the metastases, can compress upon the cord, and you can get bowel and bladder dysfunction if it's lower down. For diagnosis, MRI is the imaging modality of choice in looking for metastases to the spine. Most patients with metastasis to the spine, if it's given to you on a vignette, they will tell you that the patient has a history of cancer. And in real life, most of the patients will know their history of cancer. It's very difficult to have cancer long enough to metastasize to the spine and not have other symptoms before then. The treatment is going to be based on the underlying cancer, and primarily it's going to be palliative care because by the time metastases are in the spinal bone, median survival is around 10 months. This is an MRI of metastasis to the spinal bone, and these are lytic metastases. So you can see here lysis of the bone. This is a patient with breast cancer, where primarily the lysis is going, the metastases are going to be lytic. And this is a patient with prostate cancer, where you see here metastasis to L3 and L5. This is called an ivory vertebrae. You also see metastasis to the pelvis. These are just these little circular metastases. The rest of it is just bowel gas. So this isn't lysis. So these are blastic metastases, not lytic metastases, blastic metastases. So you see denser bone.